This is Lauren Dunlap, Executive Director for Advocacy and Awareness for Immune Disorders Association, or AAIDA, in Charlotte, North Carolina, and I'm happy to host this afternoon's educational webinar. AAIDA's mission is to provide support and advocate for the greater than 25 million Americans living with immune disorders. AAIDA works to promote research and create better awareness of immune disorders. This is AAIDA's third educational webinar for 2023, and I'm so pleased to be joined by AAIDA's own Medical Advisory Board Chair, Dr. Michael Rigas, Pharm.D. Dr. Rigas is a retired Chief Clinical Officer Emeritus, co-founder and principal at Cabo Fusion, which is dedicated to managing IVIG and other chronic and acute therapies nationwide. Dr. Rigas was also Associate Chief Innovation Officer for Pharmaceutical Care for Geisinger Health System and Chief Clinical Officer for VITALine CareSite Pharmacy Services. Dr. Rigas has served as the Senior Vice President of Clinical Affairs at Crescent Healthcare in Anaheim, California. And you have quite the resume, by the way, Dr. Rigas. I forgot to tell our audience that. Very decorated.
Well, you don't have to go through all the gory details. I think they got the picture here.
He's very decorated and very dedication to patient advocacy and access to care and treatments, which is why he is our Medical Advisory Board Chair and a dear friend as well. So you don't want me to continue? Okay.
I don't think you need to.
Okay. Well, thank you, Dr. Rigas, for joining us and covering this important topic today. I will let you take it away from here then.
All right. Thank you, Lauren, and welcome everybody to our webinar for today. I'd like to start by talking about the important part is what they are, what are biosimilars, and what do they mean to you. And so it's important if we start off by thinking about, most of us already know about oral generic drugs. And most of the time when we get a pill for blood pressure or diabetes or hypertension, we're mostly getting generic drugs these days, and they're much cheaper, and most of the time, probably 99+% of the time, work as well as the innovator product and save a lot of money for everybody. So long ago, about 2010 or so, it was proposed that injectable and infusible generic drugs receive different kind of classification with the FDA, and they became known as biosimilars. They're also called follow-along biologics, and that biologic is the name that's given to large molecule drugs that are intended mostly to be given by injection or by infusion. In some cases, they could be given orally. We'll talk about that in a few minutes. So basically, biosimilars are like the oral generic drugs we all know and well, with a few significant differences. Oral generics are typically small molecules, and biosimilars are large, and I have a slide here to show that. So here's aspirin, and you can see this is carbon, hydrogen, and oxygen. So there's about 20 atoms total in an aspirin molecule. And you can see down here for the drug Remicade, there's about 10,000 atoms, or more like 20,000 atoms, or more in a large molecule, and that's why this is so different than we're used to seeing. As well, here is insulin is showing that about 500 or 600 atoms make up an insulin molecule, again compared to aspirin with less than 20. So it's important to note that we're talking about these large molecule drugs. That's what's important about them, is they're much bigger. So they are FDA approved copies of the original innovator drug product. They're allowed to be licensed and approved in the United States once the FDA, once the innovator product's patent expires. They were part of the Biologics Price Competition Act, introduced by former and Senator Edward Kennedy in 2007, were passed and signed by Congress by President Obama in 2010. So here are some important operating principles for biosimilars. Number one, any difference between the biosimilar and innovator product must not be clinically significant. Number two, must be similar in their ability to cause immunogenicity, and that is a complicated word that means when you take the drug, the innovator drug or the biosimilar, you are supposed to develop the same amount of autoimmune antibodies to it, which in most cases would be very small, but that's an important concept to make sure you don't become allergic to the new drug. Must be similar in their pharmacokinetics, that is how the drug is absorbed and eliminated in the body. It must be similar in the pharmacodynamics, that's how the drug affects the body. Does it cause your blood pressure to go down, your heart rate to go up? Does it cause all the other things that we see for these drugs? It must be similar in their safety profile, their purity and potency, and it must be FDA approved for at least one or more of the indicators that the innovator product was FDA approved for to begin with. So it's important to think about these concepts. The first drug that was FDA approved as a biosimilar was the biosimilar version of Neupogen, which is a drug that is a large molecule that raises your white blood cell count and is frequently very important to somebody getting chemotherapy. And it was introduced in 2015 as the new product Xeraxio. Most commonly, the biosimilar product's acquisition price, and this is the important concept, is 20 to 30% less than the innovator product, which is supposed to have a cost-effective impact on insurance. So if you're a patient and you need, for example, you need Remicade, the biosimilar should be, say, 30% less, and theoretically your out-of-pocket costs for your insurance company should also be less. And that's the main impact that should have on the patient. As of recently as this February, there are 39 biosimilars approved for sale in the US, and there are about 21 currently being marketed, and they're for about 11 different innovator products. I'm gonna jump out of this again and show you a listing of what they look like. So this is how we look at them. Let me make this a little bit bigger. So for example, you can see my screen here. So let's look at, let's see if I can slide this down a little bit. Here's the drug Remicade, which everybody pretty much knows about. Here's the brand name. Here is 3 different biosimilars that are now launched and approved, and they're all in the market already. Inflectra, Renaflexis, and Aviziola. Those all have names that are not the same as Remicade. And you can also see that there is another one that's coming out right now. So there could be pretty soon 4 biosimilars for the drug Remicade. You can see the drug Enbrel, which you all see on TV commercials for arthritis. There are 2 of them coming out. And for Humira, which we see, there's one that's already FDA approved now, and there's a couple new ones coming out. You can see many more are coming. So this is going to become a very confusing marketplace in the very near future. Again, if we go up this here, we can see this is the drug for white blood cells. This is the Neupogen we talked about. Here's the Xeraxio. There are 2 other ones available. Here's one for red blood count to raise that. There's another one. Here's one that is meant again for white blood count, longer lasting. You can see there's a bunch, and they're still, you can see this is going to become very complicated very rapidly. So let me get back to my slide. So now we can see that with all these available, we need to discuss the impact of them on these very important subjects here. So the first one, so the American healthcare system is an important concept. So as of late 2022, I said 39 approved of 11 previously brand name drugs, with 22 currently available. It estimated in 2021 that biosimilars saved over $7 billion in drug acquisition pricing. And therefore that also could be inferred to save a similar amount, maybe 10% of that or 20% of that in out-of-pocket patient cost. So that might have saved 700 million or something like that in out-of-pocket costs, which is important. It's also been shown that patient access to medication is improved once a biosimilar becomes available. As we'll see, there's some things that are going to be coming up that are going to be complicated. So the impact on patient out-of-pocket cost overall, the cost savings of impact of biosimilars in the US has not had the expected impact due to some factors which will show below. As a result, many regulatory updates to the Affordable Care Act that got approved have been proposed. The main issue has been strategies enacted by the innovator, that is, in this case, our example, Remicade. Once their drug went off patent and we began to have biosimilars, then the people who made the brand name Remicade, they decided they want to try to get as much continue business as they can. So they may have interactions with insurance companies where they give those insurance companies a pricing structure so the innovative product can still be competitive against the biosimilars. So that makes for a very strange future where normally every oral generic drug is cheaper than the brand name, and you never can get the brand name unless you fail the generic. As we're going to see here, in many cases, these actions cause patients to pay more out of pocket than they might be according to the biosimilar model concept. Now, the impact on the patient's out-of-pocket cost directly, as we said, there should be 25 to 35% less. So the patient's typically paying 10 or 15% of the total cost as they're out of pocket based on their insurance plan. They should be expecting to pay 25% less out of pocket. But the insurance companies are supposed to pass that lower price to the patients. However, many innovator product companies, as I said, are offering significant rebates. And then the patient may be forced to pay a higher out-of-pocket cost that go with the innovator product, which your insurance company may force you to take, and only can get the generic or the biosimilar product if you can prove that you can't take the innovator product because you have side effects or adverse reactions, which is unlikely. Okay, so this type of innovator product rebate circumvents the original intent of the biosimilar model concept. In many states, legislatures and patient support groups are advocating now to end these practices so that more patients can experience a lesser out-of-pocket cost intended to be part of the biosimilar concept. So furthermore, the impact on ordering physicians is going to be significant. As you might imagine, they may also be adversely impacted because since they may not have control over which product are approved for their patients, the innovator product or the biosimilar, as individual insurance companies' strategies vary. So for example, an ordering doctor with 100 patients on Remicade, as I said here, they may wind up with dozens of patients on each of the 4 available products. That is, maybe 25 patients on the brand and 25 patients on each of the 3 generic or biosimilar products available. And it may result in, this represents a complex situation with an ordering doctor who may face various clinical and financial concerns and responses from their patients about the drugs that they're forced to take by the insurance company based on that insurance company's formulary. So for example, the doctor may only be familiar with Remicade and one of the 3 available biosimilars, and now that doctor may have patients on other ones they may not be familiar with. The patient may have questions about the dose size or the vial or other things, so it may be difficult for the physician to keep track of all these things given the fact that there's going to be so many biosimilars available. The impact on insurance companies is also complicated. They have a great opportunity to create strategies that could save money for the patients by encouraging their use. Alternatively, insurance companies may obtain rebates, as we said, that may make the patient pay more. Either way, the process is complex and time-consuming and involves much time and energy on all of the parties involved here. These policies are also very transient. As you saw from the graph I just showed you, many products are scheduled still to come out, and every time a new product comes out, the insurance company has to figure out if we can embrace it over what we're already embracing, another generic or biosimilar, or are we going to embrace the brand product or something. So these policies may change whenever another product comes out, or as contracts and negotiations change every year. Usually at the end of each year, all the changes to insurance companies' formulary are enacted, and this is where we expect to see major changes. Usually the notification comes out in October. That's going to tell you what's going to happen the following January. So the impact on patient and caregivers is significantly impacted since they may have the ability to save out-of-pocket costs versus the use of the brand name drug. However, based on what we discussed above, they may have to pay higher out-of-pocket costs than expected if they were prescribed a drug with an available biosimilar. Also, since most patients are likely to be on these drugs for the significant part of the period, like the rest of their life, they may be forced to switch between products and experience a change in out-of-pocket costs each time as the insurance companies update their formularies. That's going to happen every year. So the fact that somebody could be on Remicade again and on it for the rest of their life because they have arthritis, they may be forced to change to one or more biosimilars or back to the brand name product. And that change could happen every year when the new year starts as these formularies are updated. The impact on pharmacies is significant, as you might imagine, because they must order and stock many versions of the same drug. They must arrange for the proper cost-effective purchasing of the drug, and they must have the ability to sell it to the insurance company. They may have to have a special amendment or a special contract amendment that allows the new product to be available for them to sell it to the insurance company on your behalf. They also have to be able to clinically manage the patients on multiple versions of the same drug, different bottles, different syringes, different names, and it can all be very confusing, even though the drug is going to be mostly the same, as we said. Boards of pharmacy who control the pharmacies in each state, they've enacted rules for the use of biosimilars as well. And typically, most states require the pharmacy to notify and or obtain consent from the physician when a biosimilar is substituted for an innovator product at the request of the payer, or as a result of which products are available to the pharmacy. They may or may not have all of them in stock. So I'm also going to show you a diagram here. And I don't have it. We're going to make it available on the website. And that other diagram, which is going to be available, shows by each state exactly what the rules are. So if you live in Alabama, you'll be able to focus on Alabama rules. If you live in Kentucky, you can focus on Kentucky rules, and so on. But every state has their own rules. And as a patient, you may be subjected to either needing to get new prescription or other things based on what the rules in your state are. So as we want to wind this up, then suggestions for navigating a biosimilar future, and this is what I think patients and their caregivers should consider. All of the above that I just mentioned, they discuss those with their pharmacy, with their physician, and their insurance company. Because your doctor may say, you know, I just diagnosed you, you're going to need Remicade for arthritis, for example. And as soon as the authorization goes through, your insurance company may say, I want you to take this biosimilar. You may then need to contact your pharmacy to find out if they can get it. And there may be a need for a new prescription from your doctor. So all this could be quite complicated. So the best way to assure that you and your family receive the best financial outcome from the biosimilar concept is always be on the offensive. And I'm about to show you how to do that. This involves knowing the key factors about biosimilars that may be available to treat your diagnoses. Creating a spreadsheet that includes the following information may be the best way. And just to reemphasize how important this is, if let's just say your drug is $50,000 a year, which may be a Remicade-like drug, you may have to pay $5,000 a year for the brand name. You might only have to pay $3,000 or $2,000 a year for the biosimilar out of pocket. So it could be a very significant impact to the patient and caregiver. So here's what I suggest to navigate the biosimilar future. Which innovator drugs are available as biosimilars for your disease? And we're going to give you an attached list. We'll attach that to the link in the website. So for example, if your doctor now says, I'm diagnosed you with rheumatoid arthritis, you'll be able to look at the sheet I just showed you, which is here, and you'll be able to see, instead of taking, down here, instead of taking Remicade, I now have the choice of Inflectra, Renaflexis, or Aviziola, and soon Imfixi, which will be launching, this says December, but not launching in the US, so I'm not sure if it's coming here, but at least these three are already here. So our first topic then is which innovator drugs are available for the disease you have. Then contact your insurance company to see which biosimilars or innovator products are on their preferred formulary, because you need to know that before you get too deep in it, wanting this drug or that drug based on what you think the savings may be, because they may not be available at your insurance company, may not pay for them. You can look up the typical acquisition pricing on the internet, on Google, so you're aware of the cost differences between the innovator product and the biosimilar. Less costly usually equates to less out of pocket for the patient. So for example, if you went to Google and you put in Remicade 100 milligram vial, it would tell you, last time I looked, I think it's about $1,000 for a 100 milligram bottle. And if you put in Renaflexis, it probably tell you it's about $750 for the same bottle. And you can then do this for any of the drugs that are listed. So you can have a pretty good idea before you ever get ordered anything from your doctor and before you ever get anything approved from your insurance company, what your potential savings are going to be. And for each biosimilar and innovator product that might be an option for your disease and with your payer, there may be financial assistance programs available that might apply to you. So again, this is where you look up on the internet, for example, with Remicade, if you wanted to get the Renaflexis brand of the biosimilar, then you could look up on the Renaflexis website and you could look and see if they have a patient assistance plan that may be applicable to you based on your financial status. Then ask your prescribing physician which innovator brand or biosimilars they prefer. Some physicians may be unaware the biosimilar concept is available for any drug or in particular, or they may be only aware of the brand name or one biosimilar, or several other ones may now exist that may be economically advantageous to you as the patient. Finally, ask your pharmacist, do any of these innovator products or biosimilars require special purchasing by the pharmacy, special purchasing contracts, payer contracts, or training or risk evaluation and mitigation, that's so-called REMS. So any of these things could cause a significant delay in your pharmacy's ability to be able to get that drug. Say you decided that the Inflectra brand of Remicade was the one that was least expensive for you. It may be that your pharmacy that you want to go to or your doctor wants you to go to may not have that brand in stock or may not be able to get it yet. So knowing all these things in advance is going to be very important, because otherwise you're going to be at the risk of learning things on the fly, which may make this very difficult to figure out how to get a new therapy started. So I want to stop there. This is a complex subject, and I tried to get through it in a rapid time course so we have time for questions. Lauren may want to also think about forwarding the questions right now. So Lauren, do you have questions coming in from the audience?
Not right now. If they can type those questions in the little box there on the control panel if they have them, because this is a ton of information that is very complex, as you said. So I'm sure there will be some clarification that is needed for sure.
So so sometimes before questions come out, Lauren and I have some questions we've been thinking about. And so right now, if we go back to the listing of the drugs here, I just want to talk about which ones are going to be very important to the members of AAIDA. So right now, these supportive care ones are mostly for white and red blood cells, and that is usually goes with oncology patients. And right now, AAIDA is not that involved with oncology patients, although there could be some. Insulin could be a significant impact on AAIDA patients and their caregivers. And so here we have at least a couple, one and a couple more coming that would be, and of course we know that the government just passed a law that all insulin for Medicare Part D is only going to be $35 out of pocket. So that could significantly impact the importance of biosimilar insulin. But if you look down here, we can see these are immunomodulators mostly for arthritis and for other drugs, other diseases like that. And you can see there's a whole bunch happening here. And I believe if I continue down, there are more drugs. Let me just see what these are. Chemotherapy agents down here and other things for, these are like Stelara and Simponi and things like that, and Solaris and Zolar that are for many other drugs that AAIDA patients and their family may be dealing with. And we can see what's coming here. And so we know this is going to be a big issue in the future and a big opportunity for patients to save a significant amount of money. As I get in my example, it could be that you're able to save 1/3 of your out-of-pocket cost for this particular drug that you need that is available as a biosimilar. So again, we're going to make this document I'm showing here available on the, not this one exactly, I have the one that's the FDA version of this. So you'll be able to log in.
Yes, it's already on. It's already on the AAIDA website, actually.
So you'll be able to look at this and see the FDA approved version, which is what this came from. And you'll also be able to see the listing by states of the rules and regulations if you if a biosimilar wanted to be prescribed for you, what your doctor and pharmacy would have to do in that state. So, Lauren, did any questions come in?
No, not yet, sir.
Okay, all right. Well, I'm trying to think of other.
Can I ask a question?
Do you want to ask a
Sure.
question? Go ahead.
Yeah, I can't. This is Dr. Thiem. Mike, can you hear me?
Hi, is this Rita?
Yeah.
Okay, hi. Oh, yeah, go ahead.
I just don't see the square to write it in, which may be why other people aren't, at least on my screen is not showing that. Do you know for other generic drugs, but for less expensive ones like antibiotics and things like that, steroids, those are available through at least through one of our local grocery stores here. They have them, and I've helped patients where they don't even go through their insurance; they just get it for the generic, and I've had them get it for $3, $8.
Yes.
Very similar.
Yes.
Do you know if these kind of drugs are ever available with that kind of symptoms, or with like GoodRx or anything like that?
So that's an excellent question. So Rita is actually Dr. Thiem and is a pediatrician that's part of our team. So thank you for asking the question, Rita. So the GoodRx card is a unusual and particularly beneficial card that applies to people who want to not use their insurance, or who don't have insurance, or whose insurance still may have, for example, your out of pocket might be $1,000 and you might be able to get the drug for $800 without using your insurance directly with the GoodRx card. So it does apply to other than the regular oral generics, and you just have to figure out when you go to your pharmacy if your pharmacy is participating in the program with GoodRx that involves that drug. So it is possible, and that's one of the reasons I said ask your pharmacy here about all these things, because they could say, when I run this against your insurance, your out of pocket's going to be, $500, and if you use the GoodRx card and buy it yourself without your insurance, it might only be $450 or $300. So that's the reason to having all these discussions and not leaving this open to just whatever shows up on your bill with your insurance company.
Great.
Well, I mean, I guess usually with specialty drugs, the GoodRx doesn't necessarily apply those, coupons to, because you don't, that's a regular pharmacy versus a specialty pharmacy.
Yeah, but it could be, it's still potential. That's, I guess, my answer is,
Right.
It isn't mutually exclusive. It could be a benefit. And when you talk to the pharmacy, so in these cases, like normally when you go to your doctor and your doctor orders a prescription for you, for example, say for blood pressure medicine, he or she already has in their electronic chart which pharmacy you use, and the prescription is transferred electronically directly to that pharmacy. And that's, that's where your pharmacy is, and you go. And if you can't afford it, then your pharmacist there may pull out the GoodRx card or something else and figure out what the options are for you. But with these biosimilar, the innovator product, again, for example, Remicade and its biosimilar equivalents, they typically would not be going to CVS or Long's or some Rite Aid. Typically, the doctor would say, I know the insurance company wants me to send it to, for example, Quorum or Option Care or, another company like that. And that company may be completely unfamiliar to the patient because they haven't ever had infusible or injectable drugs before. So typically, the pharmacy those prescriptions go to is not one that the patient's familiar with. And therefore, when the pharmacy calls you and says this is CVS or Quorum or Infusion or whatever company it's going to be, then they'll say, we just ran this against your insurance. Your out of pocket is, I'll just make up, is going to be, $1,000 a month, and therefore, are you able to afford that? If you're not, then are there other less expensive versions of the same drug that your doctor didn't specifically order? And if you can or can't deal with that, then they might be able to apply some other discount. Or that's why I also said here in the slide up here that might have a financial assistance program that might be available. So some of the companies have those available as well, along with the innovator company. So once you talk to the pharmacist that's going to be managing your biosimilar or your innovator drug like Remicade in this case, they're the ones that are most likely going to know which ones have programs available, which ones did that particular pharmacy apply a good RX card to in the past, and therefore what does that mean for you? So it's a little bit more complicated than going to a regular retail pharmacy like a CVS or Rite Aid, and the prescription's already there, and you already know it's pretty much available as generic, and probably 80% of all the drugs people get at a retail pharmacy are generic now, and everybody's used to that. But this is the very beginning of generic injectable and infusible drugs.
Great, thank you.
I'm putting the link for the FDA link in the little chat so folks can have access to that. It is on the AAIDA website, but I will tell the audience when you click on that, it says last updated was December of last year, so it obviously has hasn't been updated in the last 4 months. Just
the one I'm showing, which is taken away from that website as well as other updated info from February 2023, and so that's a little bit newer. But the other thing is, you might, even if you log into this, which I'm trying to do now, it doesn't seem to be allowed because I'm not live on it. But if you log into the website with the FDA and you can see what's available as far as generic biosimilar drugs for your innovator product, then you can go directly to the internet to Google and type that word in, or you could say, if you think there might be more than showing, you could type in, say, which biosimilar drugs for Remicade are currently available in the United States, and that would pop up. So between the internet using Google or whatever search engine you want to and the FDA site, you can get a pretty good idea. But this requires a significant amount of coordination because the doctor may or may not be aware, the pharmacy may or may not be aware or able to get the drug, the particular biosimilar, and the insurance company usually is the first person to see a biosimilar coming and decide on the strategy they want to use, because typically it can save them a lot of money as well as saving the patient money. So usually the insurance company is up to date in real time, and the physicians and pharmacies may lag, because right now I have another chart open that I won't show you, but for example, with this listing of the biosimilars here for the Remicade that I was showing you here, I have another chart which shows that Inflectra is getting about half of all the, I'm sorry if I say that again, Remicade's getting about a third of the total business now, Inflectra's getting about a third, and the other two are getting each about 1/6 of the remaining third. So it can depend on which one came out. You can see this one came out first, 2016, this is 2018, 2020. So it may take a while for these to catch on, and there may be strategic moves on the part of the makers of these generic biosimilars. There may be strategic moves to lower the price dramatically. So this Viziola, for example, I'm not saying this is the fact, but I'm saying they could have lowered this to be half as much as the Remicade, get a lot of traction. Then when they get going and think they're where they want to be, then they could begin raising the price. And one of these three drugs is exactly the same price as Remicade, which is crazy, and the other one is about 1/3 less, which is where I think they both are now. So this is a very dynamic situation, and it can be very difficult for the patient, physician, and pharmacy to navigate, because they're always going to be playing catch up to the insurance company, who's mostly going to be right on the spot trying to do everything they can do to save money as soon as possible. So,
Mike, or Dr. Rigas,
yep.
with this is a very complex situation and multi-layered, and quite frankly, most above a lot of folks' head. So my question to you is, if you had to pick 3 of the biggest takeaway for patients, what would those 3 takeaway bullet points be that you feel are most important around this topic for patients to understand or grasp?
That's a great question, Lauren. I think the first
Might be
one,
a loaded question, so I apologize.
No, I think that's a great way to bring us all back to the point of this all. So I think the first one would be to be aware there is a concept of biosimilar, And if you're prescribed an injectable or infusible biologic drug that there is possibly a biosimilar available for that could save you money to your out-of-pocket. So that's the first thing. So be aware that you might have the chance to save. Okay. The second thing I would say is usually you're with your doctor and the doctor is telling you, I just gave you a diagnosis, for example, in this case of rheumatoid arthritis, and I want to prescribe the drug Remicade for you, and I'm going to hopefully use the biosimilar Renaflexis, for example. So as soon as you hear that, you're now aware that you have potential to save. Your doctor wants you to use a particular one. Then the next thing to do is to begin coordinating the relationship between your doctor, your insurance company, and you. Okay, and that is, what is the least expensive thing that is available that is going to be the most safe and efficacious for me? And that may not be something your doctor knows about because it might have just come out last week. But if you call the insurance company, they might say, we have 4 drugs now available in place of Remicade, and the least expensive one that we'd like you to be on is XYZ. You may need to go back to your doctor and say, doctor, this drug is available now as a 4th kind of biosimilar, and my insurance company likes it the best, and that's the one they want me to be on. What do you think about that? So the first one is to be aware. Second one is to realize you're going to have a discussion between you and your doctor and your payer. And third is that this is going to change.
Mike, before you hit on the third point, I just wanted to mention that the physician's office should have staff that can help with navigating that process with the insurance company.
Yes,
that in itself can be quite overwhelming.
Yes, when I'm saying that you should talk with your physician and payer together, I'm talking about the staff in the office are going to help you with the authorization. With the insurance company, they may not know which one. Your physician office may not know all the different biosimilars that are available. They may not know which one your particular insurance company likes the best, and therefore which one your insurance company is going to want you to be on. And so there may be coordination, there may be issues of the authorization process, and usually the doctor's office should have supportive staff that's going to be doing that to help you.
So I didn't mean to cut you off. I just wanted to know that can be challenging.
This is a complicated subject, and anybody's thoughts at any time are welcome. So finally, the third point is, and I think this, after everything we talked about, being aware and be able to talk with your doctor and insurance company, that is to realize as soon as you think you've got the best deal you can get, that this may only last for a year. So the third point is this is transient, and that is new products come out every year, as well as the insurance company may come up with a formulary update every year. And so, for example, let's just say Blue Cross of California, they may have liked, let me just go back to the slide here so I can use an example here. So Blue Cross of California, for example, may prefer Inflectra for 2023. And you just got a new prescription of Remicade, your doctor wants you to be on Inflectra, and your insurance company likes Inflectra, so everything's good. And you begin getting your prescription and your infusion, say, in April of 2023. It could turn out that for 2024, Blue Cross of California is now going to be having Viziola as its primary formulary product, and starting in 2024, they're going to want everybody, including you, to be on it. So just when you think that your life is good, you can afford your out-of-pocket, you worked out all your financial support, everything from Inflectra, it could turn out that in 2024, which is only 8 months away, that you could be asked to switch or forced to switch, and this could happen every year. And so this is hardly happens ever with the oral generic drugs, because there's typically more than 4 or 5 brands that make the same blood pressure medicine, for example. So this hardly ever occurs, and because they're all so inexpensive and there's hardly any rebates going back and forth between the maker and the insurance company. But in this case, as we've explained, this is going to be a very complex relationship. So the third thing I want the third take-home point is just when you think you got everything the way you want it, you better be thinking that at the end of each year it has the potential to change.
As
And
the formularies change,
as the formulary changes or as new product come out, it could be that you, as a aware patient or family member, you might look on a website and all of a sudden see there's now, for example, even though it says not launched in the USA and Flixi is now available here, it could be only half as much as even Inflectra is. So it could be you as the family or caregiver of the patient who now is pushing to switch to something else. You could be saving another $300 a month by doing this, for example. So it could be that you're be forced to change on a yearly basis because of the insurance company, or as I said back to number one, being aware means looking up every 6 months or 12 months or whatever on the internet to see what's available as new biosimilars for the drug you're taking. Because many patients, the difference of $300 or $400 a month is very significant and should not be overlooked. And if you're not advocating for yourself, it may be that you're missing an opportunity. So as we normally say at the end of all these talks that we do with AAIDA, you can always call us at the AAIDA 800 number or email us at the info at AAIDA line, which Lauren can tell you what the exact info email address is. But many patients call and ask us to help interpret and help them figure out how to get through these complex issues, and we're happy to help with that. So any other questions come in?
And if they want to email, it's info@godoaida.org is the email.
Okay.
No, sir. Sorry.
Okay, so no other questions came in. Anything else from you, Lauren, or Dr. Thiem on the phone with us now?
Not from me. I'm good. Thank you.
I do not.
Okay. Well, I suspect we'll be getting a lot of questions about this, so please make use of the info, godoaida.org, and we can help you directly by calling you back and reviewing exactly what's available and how that may impact you.
Thank you, Dr. Rigas, for sharing this very complex issue with us today and educating our community and just volunteering your time for AAIDA and with our audience members today. Thank you to our audience members for tuning in, and please do take a few minutes to fill out a quick survey at the conclusion of today's webinar. And if you did enjoy this presentation, please consider making a tax-deductible donation to AAIDA at www.godoaida.org. Your contribution helps us to be able to continue and conduct educational initiatives such as today's webinar. This is our next webinar coming up on May 24th, I believe, around autoimmune neurological conditions. And I'm very excited to have Dr. El Khoury on with us again. She's a fabulous presenter, and this is going to be a super interesting webinar. So this is Lauren Dunlap for Advocacy and Awareness for Immune Disorders Association, and we hope you have a healthy afternoon. Thank you so much.
Bye, everybody. Thank you for attending. Thanks, Lauren.
Thank you.
Bye.